Today we have Dr. Schwartz. He's going to talk about minimally invasive approaches for skull base meningiomas. Dr. Schwartz is Vice Chair for Clinical Research and is Professor in Minimally Invasive Surgery and Professor of Neurosurgery, Neurology, and Otolaryngology, Director of the Center for Epilepsy and Pituitary Surgery, and Co-Director of Surgical Neuro-Oncology at Weill Cornell Medical School at New York Presbyterian. I had a chance to be with him and learning some of these surgical techniques, and also to write some papers about craniopharyngiomas. I feel honored to have you here. I'm very happy to share with you. And thank you very much for sharing this topic with us, Dr. Schwartz.
Edgar, thank you so much for having me. It's really a pleasure and a privilege to speak to all of you guys. And it was great having you when you came to New York and getting to know you and working together. You did such a great job. So I'm glad we're keeping this relationship alive, and, you know, happy to be speaking to the neurosurgeons in Colombia and whoever else is logging on. So I'm going to share my screen, see if this works. And does that look good? Can you see it?
Yes, sir.
Okay, great. So what I'm going to talk about today are minimally invasive approaches and surgery for anterior skull base meningiomas. And a lot of them use endoscopy, and it's mainly through endonasal and some keyhole surgical approaches around the orbit. I have a few disclosures for different businesses that I'm involved in. Just want to thank some of the fellows and residents who've helped me out with some of this data. And I work at a Cornell in York Presbyterian Hospital in Manhattan. We created an institute for minimally invasive skull base and pituitary surgery with Dr. Vijay Anand in 2000. We've been doing these cases since 2004 for now over 15 years. So we've gotten a bit of experience. This is what the OR looks like at our institution. We usually, have a brain lab, a couple of monitors, and I operate with a scope on the holder, which is a little different than a lot of other centers. And I'll show you videos of how that's done. But, I find that the most comfortable way to work. And I just move the scope around on the holder quite a bit. And I can usually also use a 30-degree scope on the holder. And then if I go to a 45-degree scope, I'll do that handheld. So let's talk a little bit about minimally invasive surgery and the concepts and why we would want to take out meningiomas through a less aggressive way. So the first major principle is there's less trauma to the patient, ideally fewer complications. We'll show you data that shows what those complications are. The procedures, though, may take a little longer. Minimally invasive surgery is not faster. It's often more difficult to do, and because you're working through a smaller orifice, so it's not a quicker operation. And the procedures themselves may be more difficult in some ways and require a longer learning curve, but we don't want to compromise our outcomes. We want to show that we're doing as good a job as an open surgical approach. And there's no question that if the same outcome can be achieved using a less invasive procedure, then ultimately the field will adopt that procedure. And these are just some examples of minimally invasive approaches in other fields that have really replaced the open approaches because of their efficacy. And the keys to success in implementing minimally invasive surgery is really case selection. It's very important to know which are the right cases to do and to study those preoperative films, know the limitations of the approach, because not every case is amenable to a minimally invasive approach. And sometimes you need to use a bigger open approach, transcranial approach to get the job done. And you have to understand what the goals of surgery are. Not every case, the goal is to take everything out. Sometimes there's goals that are decompression of certain structures. And so you just have to have a good understanding before you go in. And then you have to acquire the technical expertise, have adequate experience. You have to have different instruments, have a plan for closure. And if all those boxes are not checked, your results are going to be suboptimal. And then the minimally invasive approaches will be inadequate because you haven't really chosen the right case and you're not really prepared to do the operation. So I'm going to start out talking about planum and tuberculum meningiomas, and I do the majority of these endonasally, not 100% of them, but many of them. And the relevant anatomy is from below is really that tuberculum sella that you have to drill out. You have to expose the optic nerves, the medial optic canal, the planum sphenoidale has to be opened up to get to the base of the tumor. And if it descends into the sella, you got to open up the sella as well. So the bone opening looks kind of like this with the opening of the medial optic canals, the medial OCR, and the planum. And the important anatomy is going to be the superior intercavernous sinus. The superior hypophyseal arteries are pushed posteriorly. Chiasm and the stalk are generally pushed posteriorly. But all these blood vessels need to be preserved. So I want to take a minute to talk about the Simpson grade because traditionally this has been how we define success in meningioma surgery and the goals of meningioma surgery. And Simpson's grading system was developed in 1957 before we had microscopes, before we had MRI scans, and before we had all the instruments that we use today. And so I would argue that this grading system really has no bearing on what we do now in neurosurgery. There have been a lot of studies showing that if you use the Simpson grade now, that there's really not much a big difference between a grade 1, 2, and 3 in terms of their long-term outcome. And the grade 4 is just too broad a category. So the Simpson grade is subjective. The surgeon himself has to tell you what grade he got based on what he can see. And the openings are not always appropriate to see everything. So that's not a great way to judge. The grades are not suitable for modern meningioma surgery. Grade 0 cannot be achieved in any skull-based meningioma, and that's removal of 2 centimeters of dura. Grade 1 cannot be achieved in most skull-based meningiomas without high morbidity. And for endonasal surgery, because you're making a small opening at the base of the tumor, you really can't assess whether there's tail that you've left behind or not. So any grading you give is not going to be accurate. So I don't think it's relevant, particularly not for endonasal surgery, to talk about Simpson grading. So the questions we're going to answer are, can minimally invasive approaches, endonasal or keyhole, provide a durable progression-free survival? And how do we select the proper case for surgery? So I'm going to talk first about planum sphenoidale, tuberculum sella, and olfactory groove meningiomas. The relevant nerves of the first two are the optic nerves, and the relevant nerve for olfactory groove is, of course, the olfactory nerve. The standard surgical approach is a pterional craniotomy, opening up the side of the head, coming in from above. But often you're working around critical neurovascular structures that you're trying to preserve, and you have to manipulate those structures. And so the endonasal approach, the advantage is it comes in from below. This is showing that the pterional craniotomy also requires a lot of brain retraction. When you open up, you really see the brain. You don't even see the pathology till you get the brain out of the way. With the endonasal approach, we can come in from below. We know that 70% of these tumors invade the medial optic canal, as you can see that here. So it's very important to open up that medial optic canal in order to get the tumor out. So you end up with a big exposure like this, where you see we've opened up both medial optic canals, and here you can see A1, ACOM, A2, optic canal, lamina terminalis, the olfactory nerves, basal frontal lobe. And sometimes these tuberculum meningiomas cause asymmetric visual loss. And I always learned that that was caused by asymmetric invasion of the optic canal. It's just showing you pre-op and post-op. But one thing we notice when we open from below and we look in that medial optic canal is often the A1 branch is compressing the back of the chiasm, the nerve, excuse me, the tumors compressing the nerve into the A1 branch. And often that's asymmetric. And I think that's what's causing most of the asymmetric visual loss. And you can see how paper thin that nerve is. And if you come in from above and you try to manipulate that nerve at all, you're probably going to damage it. But from below, you barely touch it. The other important landmark here, this is the ophthalmic artery, which is medial and inferior. And it's very important when you open the optic canal not to damage the ophthalmic artery. Here's another example of what that A1 looks like through a very thin optic nerve. And you can see how this would impact vision and how delicate that nerve can be. This was a case that was sent to me of a recurrent tumor after a craniotomy for a planum meningioma. And you see where the tumor grew back. There's the optic nerve, there's the carotid. The view from above has that blind spot in the medial optic canal if it's not adequately opened. And so that's where the tumor can grow back. But if you come in from below, you can open up that whole medial optic canal and get the tumor out. The diaphragma sella is also easily resected from below by opening up above and below the superior cavernous sinus and exposing the top of the pituitary gland. So I'm going to show you this one case. There's been some talk about the cortical cuff and encasement of vessels. This one doesn't have a cortical cuff. Looks like it may be wrapped around the A2 branches. You can see the A2 there in the tumor. You can see the A1s across the top of the tumor there. You see there's invasion of the medial optic canals, but it's a pretty good case on the sagittal. You obviously have to open the planum all the way to the front of the tumor and open down into the sella. But often what looks like arterial encasement has a good plane around it, and you can dissect it out. So here's a video of us first harvesting a vascularized nasoseptal flap, exposing the sphenoid sinus, drilling down all the septations flat, opening up the bone at the base, opening up the planum with this reverse kerosene, exposing the tumor in the medial optic canals. We cut into the tumor and internally decompress it. I like to come across the top of the tumor first and work my way down so I can find those A2 branches. And then you'll see we sharply and bluntly dissect the tumor, cauterize it down, and dissect it away from Hubner and the A1 and A2 branches. This is an eloquence device that I use to decompress the tumor, and then use scissors. And then we're opening up here the medial optic canal on the right, and we're going to roll the tumor out of the medial optic canal away from the optic nerve. And then we'll open the medial optic canal on the other side. We're constantly internally debulking the tumor, either with suction, bipolar, or that eloquence. Here we're opening up the canal on the other side, rolling the tumor out of the canal and exposing the nerve. Now here the tumor is very stuck to the nerve, so we have to sharply dissect it. Then we're going to open up above and below the superior cavernous sinus, cauterize and cut the superior cavernous sinus, take the diaphragma sella, and then we'll roll the tumor up, and you'll see the stalk here. We'll dissect the tumor off the stalk, and then we should be able to remove the whole tumor. Now in this case, we used a gasket seal closure, which meant harvesting fascia lata, slightly larger than the defect, and then wedging in a piece of medpore. I'm going to show you a different closure that we're using a little more often now, which is the button closure with Alamax. So we don't, or Alloderm, we don't harvest any fascia lata anymore. And then we cover that with glue. So post-op, you can see the A2 branch there. You can see the fascia lata there. You see the gasket seal there with the medpore. You see the anatomy preserved nicely in a gross total resection of the tumor. This is just an example of another case, just showing you pre-op, and this is immediately post-op, the results we can get endonasally. Here's another case with a more flat planum. You can see the A2 branches above the tumor and the carotids on either side, but the tumor doesn't encase the carotid. You know, it goes just to the lateral margin, but it's not fully encasing it, so that's a case we can get out endonasally. This is post-op day 2, showing you the chiasm is sunk back in, how nice that looks. This was an interesting case, meningioma that was going into the third ventricle that we did endonasally, just showing you above and below. So this was behind the chiasm. This is a case we did not do endonasally, but it's not because of this view, it's because of this view. You can see the dural tail really goes past the lateral optic nerve, and that's a criteria we use. If it goes way past the optic nerve, here you can see the tumor is completely encasing the optic nerve. So this would be very difficult, if not impossible, to get out endonasally. So this patient had a craniotomy. You see the tumor encasing the optic nerves. So the last time we looked, we had done 61 suprasellar meningiomas, mean volume about 12 cubic centimeters. And the first 8 we did before 2008, we really didn't know exactly how to close the skull base. We didn't have all the instruments we needed. And then the next 53 we did from 2008, 2017, gasket, nasoseptal flap, DuraSeal. And you can see how much better our results. We went from a gross total resection rate of 63% to 92%, and craniotomy gives you about 84%. And visual improvement was 83% versus 57% for craniotomy. That's reviewing the literature. And that's one of the big advantages of the endonasal approach, is that the visual outcomes are better. This is the Csf Leak Rates. I'm not sure where those blue lines came from. It's kind of interesting. Let me see if I can erase that, actually. Erase, yeah, somebody's writing on my screen, which is kind of weird.
Yeah.
So the CSF leak rates went from 25% to 6%. So they're not zero, but we can get them down pretty low. And 2 of the 3 patients who had leaks were obese patients. We couldn't place a lumbar drain. And then we did a cut down procedure, put a lumbar drain, and those leaks stopped. So lumbar drains do work for high flow leaks. So then we published this article comparing the rates of gross total resection, CSF leak rate, and visual improvement, comparing transcranial surgery to endoscopic skull base surgery. And first we looked at 2012. And you can see the gross total resection rates before 2012 were a little bit lower. CSF leak rates were too high. Visual improvement was a little better, but these rates really were not so great. But if you look at where the field went in the next 5 years, the gross total resection rates went up to 92%. CSF leak rates at some centers were at 0%. And the visual improvement rates went up way higher. So the endonasal approach really is better than the transcranial for well-selected cases in terms of visual improvement, with slightly higher rates of CSF leak rate. We want to do a study comparing the two, and it's very hard to do by reviewing the literature because of selection bias, right? So you're not going to get the same tumors taken out with each approach. You'll probably get smaller tumors taken out endonasally and bigger tumors taken out through a craniotomy. And so you need to compare apples and apples and oranges to oranges. So you really want to look only at cases that could be removed endonasally, and then look at the results of those cases being removed through a craniotomy and compare them to those that have been removed endonasally. So we did that study at our institution. And what we did was we took all the plano meningiomas removed transcranially from 2000 to 2015, endonasally from 2008 to 2015, because this was really when we knew what we were doing, whereas craniotomy really didn't change during that time period. We created a PowerPoint of axial, sagittal, coronal scans, sent it to 3 experts in endonasal surgery and said, which of these cases are good candidates for endonasal and could be removed either way equally well. So these are examples of endonasal cases we did. This is an example of transcranial that we chose to compare because the experts felt this could have been taken out endonasally and a gross total resection could have been achieved. So we had 33 patients, 18 underwent endonasal surgery, 15 transcranial. Pre-op tumor size was comparable, no significant difference. Preoperative flare in the brain was comparable. Gross total resection for endonasal was 82% and for transcranial was 53%. So definitely lower, but we didn't have the power to show significance. Extent of resection was 98% in endonasal and 95% in transcranial. So again, a little better in endonasal, but we didn't have the power to show significance, but we definitely showed non-inferiority. So we're getting out as much or more tumor endonasally. When you look at flare signal in the brain, transcranial had an increase of 4 cubic centimeters from brain retraction. Endonasal had an average of negative, meaning basically 0 flare signal in the brain, and DWI volume indicating potential stroke or permanent contusion for transcranial 2 cubic centimeters and endonasal 0.4, so much less. And if you look at visual improvement, endonasal was much better, 67% versus transcranial 25%. Visual deterioration was much higher with transcranial than endonasal, and that was statistically significant. If you look at other complications, transcranial was also higher than endonasal. If you put them all together, seizure, stroke, hemorrhage, and paralysis, CSF leak, endocrine disorders. So that data really showed that the endonasal was as good or better, particularly with respect to visual improvement. We wrote this paper also just to analyze and undermine the myth that you need a cortical cuff, and that if there's no cortical cuff, it's a contraindication, or if there's brain edema, there's contraindication. We basically found the most important thing is careful case selection and surgical experience. The cortical cuff and brain edema really made no difference in outcome. So in this study, we wanted to look at long-term outcomes and predictors of subtotal versus gross total resection for endonasal resection of suprasellar tumors. So we looked at 51 cases. We were able to achieve a gross total resection in 40 out of 47, which is 85%. And then we looked at different risk factors that might lead us to only get a subtotal resection to see what was important. Was it size? Was it reoperation? Was it vascular encasement? Which artery, ICA versus ACA? How much encasement? Optic canal invasion, one canal or both canals? And we devised this new score, which we called an optic laterality score, which is basically what percentage of the optic nerve is the tumor wrapped around. And the one that's most important is the 100%. So if the tumor goes past the lateral margin of the optic nerve, it has a 100% optic laterality score, which would be a 3. And 2 would be if it only goes 50% of the way. And what we found was the biggest risk factors for incomplete resection, for endonasal surgery, for tuberculum and plano meningiomas was prior surgery, so reoperations we didn't do as well, tumor lateral to the optic nerve, which we just spoke about, complete internal carotid artery encasement. So that's 360 degree encasement of the ICA. So it wasn't as important if it was 180 or even 270. And we found that tumor size was not significant, nor was encasement of the anterior cerebral arteries. And then we looked at the outcomes. So we followed them for about 40 months. And we found that only one of our gross total resections recurred. And that one actually transformed to an atypical meningioma. And we know that that predicts recurrence as well. But if it didn't transform, all our grade 1s, we had no recurrences. If we had a near total resection or a subtotal resection, any residual tumor, those grew at a very high rate. Vision was stable or improved to 93.5%, and we had 10% post-op Csf leak rate, 4 of which were managed just with a lumbar drain. Didn't require reoperation, only 1 did. So we developed a scoring system to try to predict who's going to have a gross total resection and who's not. And we gave a point for each of the factors that we found. And if you have none of those, then your chance of a gross total resection is 95%. Even if you have one of those negative predictors, it's still 93%. But when you have 2 or more, those numbers go down a lot. So that's what I think about in my head when I'm looking at a case and saying, can I get this tumor out? Will I be able to get a gross total resection or not? These are the survival analysis curves for progression of the tumor. And as you can see with the gross total resection, the green line, there was only 1 recurrence, and those stay pretty stable. We used several different types of closure, one of which is the gasket seal, where we use an onlay of either alloderm or fasciolata and wedge a piece of med-pore in place. And that kind of looks like this. We cover that with a vascularized nasoseptal flap and some kind of a glue. If you use a gasket seal, you have to make room for the optic nerves. You have to cut out little slits. Let me see if this will show. This is an example of a button closure. We are moving, if you want to do a soft closure, sometimes we do this. You do an inlay of Duraform, and then we'll do a dual layer Allomax or alloderm. If you don't want to use fasciolata, you can use you sew it together and you do an inlay of Allomax, and then you tuck that in, and then you do an onlay on top of that, and then you cover that with a vascularized nasoseptal flap. And that's another type of closure if you want to do a soft closure and you want to avoid using fasciolata. You don't want to make another incision. And there's the green glue, the adherus. I want to talk briefly about olfactory groove meningiomas because I do not think these are good candidates for endonasal surgery, but I do think they're good candidates for an eyebrow incision. I want to talk about that. So this is the traditional approach, big bifrontal craniotomy, take the sagittal sinus, take down the frontal sinuses. In this example, they're taking the ethmoid arteries, from within the orbit. And when you look at the transcranial approaches, and this is a paper that looked at 100 cases, bifrontal, terional, frontoorbital, basal, and you look at the complication rates, there's a pretty high risk of retraction-related brain swelling, bleeding, 10%, 15% of the other, and death, 3.5%. So the risks are pretty high, but what you don't see here is anosmia. And that's because a lot of these papers, they don't even consider an anosmia complication, but it really should be, because not everybody presents with loss of sense of smell, and you should try to preserve the sense of smell in these patients. The endonasal approach, and this is the largest series from a couple of years ago, also is not ideal. The length of surgery in this presentation was 9 hours. Length of stay was 11 days. 36% of the patients needed a reoperation to remove more tumor. 30% needed a reoperation to repair a CSF leak. And the gross total resection rate was only about 45%. And if the tumor was greater than 4 centimeters, the CSF leak rate was about 40%. So these results are not great. And it turns out that if your tumor is less than 4 centimeters, the chance of you being anosmic is only 4.5%. And that was the case in this paper, but their post-op anosmia rate was 100%. So they had a 95% increase in anosmia doing an endonasal endoscopic surgery. So this is just the results of their publication for endonasal approach: 30% CSF leak rate, 8% respiratory failure, 6% hydrocephalus, 6% brain abscess. And their leaks really didn't come down even with a nasal septal flap. So in answering the question, which is a better case for an endonasal approach, the answer is neither, because the big tumor, you're not going to be able to get completely out with an endonasal approach. And the small tumor has their sense of smell intact. And if you take it out endonasally, which you can do, you're going to cause anosmia. And olfaction is really important. It's also important for our sense of taste. So olfactory preservation is not possible in endonasal surgery. If you do a craniotomy, though, about half the time you can preserve olfaction. And if you have pre-op olfaction intact, you can preserve it about 85% of the time. If it's impaired, it goes down to 42%. And also based on the size of the tumor, the bigger tumors, you're less likely to preserve olfaction, but with smaller tumors, you can. So when we look at olfactory groove meningiomas and we compare transcranial surgery results to endonasal surgery results, and we look at early results, transcranial gross total resection is higher, CSF leak rate is lower. Visual improvement really not as important for olfactory groove meningiomas. And what you see is that if you look at the more recent data, the gross total resection rates really didn't get any better for endonasal surgery. And the CSF leak rates didn't really come down that much. The visual improvement rates went up a bit, but they're pretty high with a craniotomy as well. And anosmia with transcranial surgery is about 50%, whereas for endonasal, it's about 100%. So that's why I don't like endonasal surgery for olfactory groove meningiomas. I do think it should be done from above, but you don't have to do a giant craniotomy. You can actually do a small eyebrow incision and a small supraorbital craniotomy to take out an olfactory groove meningioma. Now, the limitation is that what you can see with a microscope is only this area in blue. And the areas in orange are invisible to you with a microscope because of the anatomy in the small opening, but they're not invisible with an endoscope. And so you can do an endoscope-assisted surgery. This just shows you the blind spots, right? You can't see down to the cribriform plate. You can't see anteriorly. You can't see past the sphenoid bone. And again, this shows you that, but with an endoscope, if you put an endoscope in through the eyebrow incision, you can see everywhere. You can see all around. So we did an early study comparing eyebrow to endonasal surgery for olfactory groove meningiomas. We just looked at 12 patients, and our gross total resection rate was higher with the eyebrow incision. Extent of resection was higher. Anosmia was much lower. It was 100% with EEA, and our complications were much lower. So we did this early study, and we said, you know what? This makes more sense to us. We're going to do eyebrow incision. And the eyebrow incision cosmetically looks great. This patient gave us permission to use her picture. This shows you the eyebrow incision. This is another patient who gave us permission, showing you the eyebrow incision. And the other thing, this is just a paper that was written on the eyebrow incision and cosmetic satisfaction, showing that the majority of the patients are very, very happy and have no pain and are very satisfied with the cosmetic outcome from an eyebrow incision. So this just shows you what it looks like. We make the incision medial to the supraorbital notch. We go lateral enough so that we can get a burr hole in the keyhole, right? Supraorbital notch is there, and we keep the incision in the eyebrow, burr hole in the keyhole. We bring the pericranium forward. This is the supraorbital nerve. I like to take the orbital rim to give us more room. So we take it in one piece, and then we open up the dura. Before we do that, of course, we drill off the roof of the orbit so there's no bumps and lumps in our way. And then you see the frontal lobe. There's very little retraction that's required. And then this is the view you get. You get a really nice view of the chiasm. And as I said before, if you want to do, if you want to go to the olfactory groove, you do have to use an endoscope. This is just another example of the steps. This is a paper this is from 2017, just a really nice example of the different steps of doing it, the eyebrow approach. And also I like to sweep down the temporalis muscle, and then I put little holes and in the arch and sew that back up. You can also use the eyebrow to get a great view of the contralateral medial optic nerve, the medial optic canal. So this is a patient who had a recurrent tumor after a prior craniotomy, and she had tumor medial to the optic nerve, but it was above the carotid. So in my estimation, the best way to get this out was to do a contralateral eyebrow approach. And if you come in contralaterally, you can see the medial optic canal. So this shows you the view that you get of that residual tumor coming from the contralateral eyebrow incision, because the medial optic canal is actually blocked if you come from the ipsilateral eyebrow. So it's very hard to see, but if you come contralateral, you can see the whole thing. And this just shows you that view. So what you see here through the eyebrow incision, if you try to get below the optic nerve here, it's very hard to see because the optic nerve is in your way. But the contralateral optic nerve, you can see the medial optic canal very, very well. This just shows you the post-op image. So here's a case I did with an eyebrow incision, decent size olfactory groove meningioma. You can see how endonasally you might have missed some of this tumor. Let me just see if the video plays. Sorry about that. Here we go. So we've taken off the orbital rim. We're drilling now down the orbit. We're opening up the dura. We're retracting it forward. I like to initially put a small retractor on the frontal lobe, and then I take that out after a while. So you do what you can with the microscope, and you can internally decompress and mobilize the tumor away from the frontal lobe and just keep internally decompressing it and mobilizing the tumor away. And then you get to a point where you can't see anymore because you can't reach into the cribriform plate. And that's where I use the endoscope. So what you're going to see next is we're going to advance the endoscope. Here we go. And now with the endoscope, you can see the entire cribriform plate all the way up to the crista galli. And I use this bent instrument called the eloquence or the Elman, and I can basically burn away the base of the tumor all the way down to the bone. You can't remove the hyperostotic bone. You can drill it flat, but you can't take all of it out. This shows you the post-op film, and you can see we've gotten the whole tumor out. So we have done, now we've probably done about 20, but at the time we put this together, we did about 17 cases. Their mean tumor volume was 15 cubic centimeters. We got a radiographic gross total resection in all but one case, 94%. The pre-op flare volume in the brain was 9.8 cubic centimeters. Post-op, it was unchanged because there's very little retraction of the frontal lobe. The post-op DWI was only 2.9 cubic centimeters, so there was very little brain damage, but not none. Length of stay on average was only 3 days. Follow-up, we have 32-month follow-ups, and we had 11 patients where we had greater than 2 years of follow-up. And only 2 of those patients recurred. One of them at 39 months referred for SRS of the cribriform plate, and one of them had a lot of tumor that extended down into the ethmoids, and we took that out through an endonasal approach. But what I really want to emphasize is vision improvement. Post-op anosmia, new post-op anosmia was only 20%, and post-op anosmia in total was 30%. So we're able to preserve olfaction in as many patients as we possibly could. These are just some circles showing you those results, which I talked you through already. But the limitation of the eyebrows, you cannot drill out and repair an infiltrated hyperostotic cribriform plate, but you can treat that with stereotactic radiosurgery. There's nothing wrong with doing that, and it decreases the risk of CSF leak. And if there's extensive bone involvement and tumor into the nasal cavity, you can use a subfrontal approach if you want, or you can combine the eyebrow with an endonasal approach. And this just shows you some of the results of radiosurgery for olfactory groove meningiomas. Progression of tumor only 5%, so you have 95% control rate. And if you look at cranial nerve 1 deficit, so this is olfaction, patients with deterioration after SRS was very low, was 0. So we have this algorithm that we use to try to figure out what sort of operation we're going to do for anterior skull base meningiomas. Basically, if it goes in front of the sphenoid sinus or behind the sphenoid sinus, we make one decision. So if it's in front of the sphenoid sinus, it's an olfactory groove meningioma. If it goes behind it, then it's a planum or tuberculum. And then we look at the lateral extension of the tumor, how far lateral it goes. And if it doesn't go that far lateral, then we do an EEA. And if it goes lateral to the optic nerve, we obviously do a transcranial approach, and there are a couple options. If it's an olfactory meningioma, we ask our question, is olfaction preserved? And if olfaction is preserved, then we do a supraorbital approach, and we use the endoscope to assist us. If there's no olfaction, we ask ourselves, is the cribriform plate invaded? And if it's not, then we make a decision based on the lateral extent of the tumor. And in some circumstances, we'll do an EEA, but only if there's no olfaction and we can get out the whole tumor, then that could be a reasonable case for endonasal surgery because it doesn't go laterally too far. I want to talk briefly about transorbital surgery, making an eyelid incision going lateral to the orbit. We use this as a route for sphenoorbital meningiomas instead of doing this kind of a big craniotomy. Some of these sphenoorbital meningiomas have mostly hyperostosis, and those are the ones I think that are the best cases for what you can see here, a transorbital approach. We come lateral to the orbit and drill that out. Because the goal is really to relieve their hyperostosis. And I really learned this from Doo-Sik Kang in South Korea, so I want to give him all the credit. He really popularized this approach. So this is a sphenoorbital meningioma, and the patient has proptosis, and most of the tumor is really just hyperostotic bone. There's not a big intracranial soft tissue component. And you can see that hyperostotic bone here that's pushing the orbit out. And so we did a little eyelid incision, and then you work lateral to the orbit, and you can drill out the hyperostosis. So here's an example of that. If I can get this movie to play. Oh, the movie's not playing. I'm sorry, the movie's not working, but you can see we have a retractor here drilling, moving the orbit medially, and we just drill out the hyperostotic bone. And you can see post-op, we've drilled all of that out, just going through a little eyelid incision, and then we relieve the hyperostosis. So my conclusion for minimally invasive approaches for anterior skull base meningiomas is basically that endonasal endoscopic approaches provide equivalent gross total resection rate with better visual outcome, but a higher rate of CSF leak. So you trade one for the other, and you're trading seizures and wound infection for sinusitis and anosmia. But in my opinion, the most important thing for planum and tuberculum meningiomas is gross total resection and visual improvement. And the endonasal approaches give you better visual outcome. Simpson grade, I think, is no longer useful for skull-based tumors, and that's a separate talk. Endonasal gross total resection appears to provide durable response and good long-term control if you choose your cases wisely. If you choose your cases poorly and you leave residual tumor, then of course the tumor is going to grow back. And that may be because removal of bone and devascularization of the tumor may contribute to preventing recurrence. So appropriate case selection is very critical. For planum and tuberculum meningiomas, the tumor, if it's lateral to the optic nerve or completely encasing the ICA or a reoperation, you're less likely to get a gross total resection. So you should consider an open surgery for that. But complete encasement of the ACA and only partial encasement of the ICA and tumor size, as well as unilateral canal invasion, are not predictors of subtotal resection. So those should not limit your ability to do those cases. Endonasal surgery is not appropriate for the majority of olfactory meningiomas. The eyebrow approach is preferable. It's a minimal access approach, but you have to use an endoscope in order to see everything you need to see. I think that is the end of my talk. So thank you very much.
Thank you, Dr. Schwartz. I'm really grateful with you. I really appreciate that it's late tonight and it's your valuable time. I just got 2 questions. I know that this presentation is focused on the anterior and middle fossa meningiomas, but I would like to know do you find any minimal invasive approach for posterior fossa meningiomas, for lateral endoscopic approaches for those petroclival meningiomas?
So a petroclival, I think, would be challenging. You know, I've done some schwannomas. Now, I don't do acoustic neuromas in my institution, so I can't really talk to that. But I've done some, I'm blanking on the name. The schwannomas in the lower, the canal below that. What's it called? I'm just lost the word.
In the lower canal?
Jugular foramen, sorry. I've done some jugular foramen schwannomas, excuse me. Small ones, and I've done those minimally invasively with endoscope assistance. And you don't have to drill out as much bone to get there. And if you use the endoscope, you can look laterally into the canal. And so I find that to be a useful approach. But I think for a petroclival meningioma, it's such a complicated tumor. You need so much exquisite control that I haven't found the endoscope to be that useful. I have found it useful for epidermoids, where I've done suboccips because, you know, they're so suckable. There's not so much blood supply. It's a slightly easier surgery. But I do worry about the endoscope, you know, going in and out with the cranial, going between the cranial nerves. You know, for some smaller tumors, I think it's good, but for giant tumors, I'm not sure at this point it's the right way to go.
Yeah, it's not comfortable. And so the other question I have is, I saw you were talking last week with Dr. Doikyu from South Korea about the transorbital approach. I'm pretty curious of how did you close to avoid CSF leaking these procedures?
So a lot of the tumors you take out are extradural anyway. If they're in Meckel's cave and they're in the cavernous sinus, you're not actually going intradural to get there. You're working outside the dura. For some of the Meckel's cave schwannomas, when they go into the posterior fossa, you do get into the CSF. And so we've done a soft button closure with an inlay and onlay of alloderm, but then when the eye falls back, the eye really compresses that area nicely. And so CSF leak doesn't seem to be a big problem because of the, you know, fat and size of the orbit compressing everything. But I do a two-layer closure of the opening just behind the orbit.
Nice. And do you use lumbar drains for those cases?
We did not use a lumbar drain, but I think it's not a bad idea to use a lumbar drain if you think you're going to get a big CSF leak, because it also will help relax the temporal lobe. And you do have to push, when you drill off all the bone, the orbit goes one way, but you have to move the temporal lobe laterally often. And so, you know, the softer that is, the easier it'll be to retract that laterally.
Very nice. Yeah. I don't know if anyone has any question for Dr. Schwartz. You know, otherwise, I'd just like to invite you tomorrow. I will join Walter Jean also tomorrow to show an endonasal case or a pituitary. I don't know.
Great.
Want to join us.
I saw that you're going to be with Ed Laws, right?
Yeah.
Good for you. That's great. Yeah, you're good luck.
Yeah, thank you very much. So I hope you have a good night, and if you have time, I will try to contact you for a next conference about minimal invasive approaches. So,
great. And if you when you put the two videos together, you know, send me the link, and I'll
absolutely. I will
All right.
share.
Take care.
Thank you
everybody.
very much.
Thank you.
Bye bye.